Um, and I'm here to learn. I'm doing a lot of training, but polypectomy training, and Lynn was very calm, very patient. I struggle with, I know I don't struggle with being calm, but I feel like I'm impatient often, and I'm perhaps take the scope off the trainee too quickly, perhaps. And so I think, and I know it's different. I think this patient is under propofol. Is that right?
That's correct.
Yeah. So it is, well, that maybe I don't know if David thinks that's an excuse that we use, but it is, I think, different.
So we talked a little bit about, do you take over the scope when the patient's doing polypectomy? So there's a few things you need to think about. You need to think about the consent process, which we will touch on maybe, but we're assuming people are consented, but maybe the patient will withdraw the training consent, not necessarily the polypectomy consent. And I think, looking back to the last case, where they're using propofol, so the patient's not aware, but particularly if you're training in polypectomy in the right colon, there's a time factor here, because as you put CO2 into the right colon, you get distension, you get tracking into the small bowel, patient starts to become restless, uncomfortable, and often a little bit vagal. So firstly, giving feedback, I think, is a difficult thing. But when you get it right, it is incredibly powerful. And I'm going to try to encourage people to try and assess from the trainee what they think, how the thing has gone. And it avoids you making assumptions about where their head is. It enables the trainees to highlight where they believe the conversation needs to be focused. And then as the trainer, you can make a judgment call on whether you think that is the priority or not. And then during a conversation with the trainee, and it is a conversation, you should be able to pull out the positives and negatives and correct and develop the things that they've mentioned, and force the trainee to reflect on what happened and why it happened. Or you can have dynamic movement. So you can have the accessory out of the channel with the needle out, and then you're going to move the tip around as we do with dynamic movement injection. Snares we can rotate. They don't have to be rotatable snares, but if you're going to do that, you have to pin and pivot the snares. There is engagement with the snare, with the mucosa. What does that really mean? What does that look like? How do we achieve that? We achieve that really by downward pressure, aspiration, careful placement of the snare. Sometimes when we're using clips, you want engagement of the leg of the clip, which has little hooks on it, to engage with the mucosa before you move the clip to ensure you get coming together the mucosa. So this is the type of language you really need to be thinking about. And it's not for me to tell you what language to use, but I think there needs to be a general agreement about what language we are going to use. And then I think it's really important that your communication is clear with the support staff. And I've said this already earlier today, but we check for understanding. Unfortunately, we tend to say a lot of things, me in particular, and we don't always check for understanding. We just assume the person has understood what you said. And sometimes things are difficult to understand, or maybe the person was distracted and didn't quite hear. And what you don't want to do is have miscommunication, which can lead to potential problems and errors. So please check for understanding. And if it's a really important point, it's worth checking for understanding, even if it looks bombed or obvious, because it's best to get it right when it's very difficult or potentially hazardous. I also think you need something called situational awareness. And what I mean by that is if you're in the room and you're aware of what's going on, it may be something like, there's going to be a polypectomy, so you can get the nursing staff to get the kit out ready that you need. It may be that you're doing a polypectomy and the trap isn't on. It may be situational awareness where you're aware that the patient is uncomfortable or the nursing staff are uncomfortable with how long the procedure is going on and you need to intervene. And we have a guy in our unit called Luke Mataraki who developed a polyp recall form. And what this is when you have multiple polyp resections, our laboratory and maybe yours, like each of the specimens in a separate pot. And although we have video capture or image capture in our recording system, when you're coming to write a report, if you've taken off 10 or 15 or 20 polyps, it sometimes gets very difficult to remember the specificities of all the polyps. And what the form does is simply records where the polyp was taken, what technique it was used, what size it was the morphology, and any other features. And when you come to then write your report, you have a reference point for doing this. And you really need some system to do that. And we haven't discussed this, but when it comes to recording the data, I think it's really important to get this right. I'd also encourage you to take a photograph before and after the polyp has been removed. So you've got a record of before you remove the polyp, and then you've got a record of the mucosal defect following its resection. And then further level is specific language in relation to polypectomy. Now, some of this is knowledge, but then there's terminology to go with the knowledge. So when you describe a polyp, the morphology of the polyp, you should really use the Paris classification. And after that, it gets a bit muddy. And the reason it gets a bit muddy is because most people will then use digital enhancement to interrogate the patterns of the polyp itself. And if you're using digital enhancement, what you're really looking at is the capillary network. So you should really be referring to JNet NICE. If you use a different system, for example, if you use things like BLI, RDI, MBI, they're all specific to certain manufacturers. So it can be confusing, but I would encourage that everyone should be able to describe the polyp by Paris and have an estimation of size, and that will be able to give you a cancer risk. And if you're not sure and want to interrogate an area, you need some form of digital enhancement. You need to refer to elements of the polyp. We talk about the base of the polyp or where it meets the mucosa. We talk about a stalk and a head and a mucosal defect. And we're going to listen in a moment to a deep mucosal inspection and if there's any deep mucosal injury. We talk about margins and having normal cuffs. And this seems, if you do a lot of polypectomy, all this stuff seems really normal. But for a trainee, maybe you have to educate them what that sort of language is. So as I say, we're just beginning to evolve this to try and get the language right.